Thank you for joining us for Talking Sleep, a podcast of the American Academy of Sleep Medicine. I'm your host, Dr. Seema Khosla, Medical Director of the North Dakota Center for Sleep in Fargo. The AASM released updated guidelines on the diagnosis and treatment of REM sleep behavior disorder a few years ago. Since that time, we have chatted with experts in the field about the nuances of disclosure and predicting phenoconversion. One important consideration is how to better inform this conversation. We know that RBD is associated with neurodegenerative sequela, but it is not entirely clear how to identify those at highest risk of phenoconversion. Dr. Luca Baldelli is a junior assistant professor of neurology from the University of Bologna. He serves as treasurer-elect on the administrative board of the International REM Sleep Behavior Disorder Study Group. He proposes a simple clinical framework for longitudinal monitoring, which may identify those at highest risk for phenoconversion. He joins us today from Bologna, Italy. Welcome. Thanks for joining us today.
Thank you. Good morning, everyone.
So you have done work in the field of prodromal neurodegeneration. Tell me about this. What does this mean?
Yes, my main research interest has been focused on the prodromal phase of neurodegenerative diseases, particularly in isolated RBD, which we now understand that is actually one of the most reliable early markers for alpha-synucleinopathies like Parkinson's disease, dementia with Lewy bodies, or multiple system atrophy. And my work has aimed to better define how we can detect early signs of neurodegeneration before the clinical onset, with a focus on objective markers and especially on autonomic dysfunction, especially cardiovascular autonomic dysfunction or cardiovascular autonomic failure.
So when we talk about autonomic dysfunction, what do you mean? Is this orthostatics, or what do you mean by autonomic dysfunction?
Autonomic dysfunction, or more precisely, autonomic failure, is actually the failure of the autonomic nervous system to respond to the outside and the inside stimuli. It is actually the most known as the cardiovascular autonomic dysfunction. And the herald of cardiovascular autonomic dysfunction is neurogenic orthostatic hypotension. That actually is the drop of the blood pressure when you are standing and the incapacity of your autonomic nervous system to respond to the orthostatic position.
So, we have chatted with several experts on RBD over the years, and it's interesting to me. One of the consistent themes is how to better inform the discussion with our patients. So, Dr. Howell taught us that patients who have anosmia, constipation, and orthostatic hypotension are the most likely to progress and develop a neurodegenerative disorder. So, is this consistent with your findings as well?
Yes, absolutely. These symptoms and signs are all signs of an underlying involvement of neurodegeneration. And our findings actually confirm that autonomic failure, especially cardiovascular autonomic failure, is a strong predictor of phenoconversion. But what we actually need is the trajectory for these patients, and we need multimodal biomarkers. Biomarkers should be in a way that it signifies the presence of neurodegeneration as a state biomarkers, diagnostic biomarkers. It allows to monitor over time, but also it allows to predict phenoconversion.
Are there current biomarkers that we should be using?
In this case, we should be using a biomarker for autonomic dysfunction and failure as orthostatic hypotension. Indeed, it's better to refer to neurogenic orthostatic hypotension, that is, orthostatic hypotension due to failure of the autonomic nervous system. We can define it as a blood pressure drop of either 20 millimeters at the systolic blood pressure or 10 millimeters to the diastolic blood pressure during a tilt test or a standing test within the third minute of orthostatic position.
So this isn't just something we ask about. This is something that we should be measuring?
Yes. Asking about the symptoms may not be enough. Many of these patients actually do not even recognize or report autonomic symptoms like mild orthostatic drops. And that's why incorporating objective testing that can be even simple standing blood pressure measured coupled with heart rate responsive can be significant and can improve our ability to stratify the risk and monitor progression.
Okay, so I heard you say tilt table, but then I also heard you say that we can do it in the office. So can you walk me through this? Do we have to start with a tilt table and then do we follow it in the office, or can we just do this in the office?
You can do in the office an orthostatic standing test while you ask the patient to rest for 5 minutes or even less and then measure the blood pressure and the heart rate. Then ask the patient to rise standing and measure it at the 3rd minute and evaluate if there is orthostatic hypotension. However, you can be also more precise. You can do neurophysiological testing by means of autonomic reflexes tests that actually allows you to evaluate the sympathetic and parasympathetic branching of the autonomic nervous system at not only concentrating on the drops, but actually on how the autonomic nervous system is able to respond to these conditions.
And is that the same protocol or is that different?
This is actually a different protocol. In the autonomic nervous system reflexes test, the patient actually rests supine for 5 to 10 minutes on a tilt table testing while monitoring the heart rate and the blood pressure beat per beat. Then the patient is tilted and it goes tilting in an head-up position of about 65 degrees, so it's not standing. Then we perform several tests like the Valsalva maneuvers, where the patient is asked to do a heavy expiration over resistance. We perform the deep breathing test, breathing at 6 breaths per minute, and other tests like the isometric exercise test, where the patient is asked to clench with his fist a resistance. Therefore, we can see that these tests actually make changes in our blood pressure and heart rate, and our autonomic nervous system adapts and responds to it. And we study how it does and if it does it in a normal way.
I was wondering how you could tell the difference if it was neurogenic or if it was, volume depletion or something like that.
We can actually do it in both ways.
Okay.
The gold standard way should be you evaluate in autonomic reflexes tests, and you see, for example, in Valsalva maneuvers, that is a maneuver studying the whole baroreflex response to blood pressure and heart rate changes. And you see if either or both the blood pressure response, that is named overshoot, and the Valsalva ratio, that is the heart rate response, are normal or impaired. However, you can do it also with a validated formula that can be used also at bedside by evaluating the ratio at the standing test between the systolic blood pressure change and the heart rate change within the 3 minutes evaluation.
So what is that formula?
This formula is actually the ratio between the blood pressure difference between the baseline and the 3rd minute systolic blood pressure and the difference of the heart ratio at baseline at the 3rd minute. If this formula actually is lower than 0.49, you can actually, in presence of orthostatic hypotension, say it with high sensitivity and specificity that the orthostatic hypotension is neurogenic.
Really? So it's not just the presence of orthostatic hypotension, right? It's you apply the formula and then you can determine that there is a neurogenic component.
Yes, the formula helps you to see if the orthostatic hypotension has a neurogenic component.
Mm,
What I would suggest is that if you actually find orthostatic hypotension and you are actually positive to that formula, I would suggest also in going in a little bit more in detail,
okay.
performing autonomic reflexes test to see also what branch of autonomic nervous system is actually impaired.
Is that the on the tilt table?
It's on the tilt table, yes, and is within the tilt table also by performing the other maneuvers like
Oh, that
Valsalva
makes sense.
maneuvers, deep breathing, and so on.
Is the presence of neurogenic orthostasis, is that something that is static or does it change over time?
The presence of orthostatic hypotension is something that actually, once you have it in isolated transient behavior disorder, it actually continues over time.
Mm.
What it actually changes is that in these patients, the autonomic nervous system deteriorates over time. So what you can actually see, you can see that orthostatic hypotension may become more severe over time, may become from an asymptomatic finding to be symptomatic for the patients. But also you can find patients which actually didn't have orthostatic hypotension, but only impairment at some of the variables at autonomic reflexes test, developing orthostatic hypotension.
So that's like an earlier sign.
Indeed, that
Okay.
is an earlier sign, and you can also find signs at autonomic reflexes test which can appear earlier to orthostatic hypotension. For example, alteration in the Valsalva maneuver.
Okay. So let's take a short break, and when we come back, we'll talk more about predicting phenoconversion and RBD. You're listening to Talking Sleep from the American Academy of Sleep Medicine.
Looking for the latest in sleep science, clinical guidelines, and research all in one place? Discover AASM Link, your AI-powered central hub for sleep medicine. Unlike other AI tools, our resources are expertly curated by the American Academy of Sleep Medicine, ensuring more accuracy, credibility, and clinical relevance you can trust. A perfect resource for preparing for the longitudinal knowledge assessment, studying for board examinations, and much more. AASM members enjoy free monthly access. Whether you're at your desk or on the go, AASM Link keeps you connected to the future of sleep health. Available on desktop and Google app. Coming soon for iOS. Visit AASM shop at aasm.org to join today.
Welcome back to Talking Sleep. We're talking with Dr. Luca Baldelli about his work on the autonomic nervous system and RBD. So, why does this happen in RBD? What's the pathophysiology?
Because RBD is not just a sleep disorder, it's a reflection of brainstem neurodegeneration. For example, the areas involved in REM sleep atonia, like the sublateral-dorsal tegmental nucleus, are actually anatomically close to those regulating autonomic control, like the rostral ventrolateral medulla or the dorsal motor nucleus of the vagus. So the pathology in the RBD, which is an alpha-synucleinopathy, often hits this region early, explaining why autonomic dysfunction can actually accompany or even in some cases precede RBD.
Well, it was interesting to me that you said that RBD was the most consistent predictor. And so I wonder, is RBD always a prodromal state? I mean, should we be checking orthostatics on all of our patients or just the ones with RBD or, when they develop dream enactment?
The majority of people with polysomnographically confirmed RBD, around 5% per year in multicenter cohorts, will convert to a neurodegenerative disease over time. So yes, I believe that checking for OH, orthostatic hypotension, in RBD should be the standard. In other population, you should be aware that not always orthostatic hypotension means neurogenic orthostatic hypotensions first, but there may be also other causes of orthostatic hypotension, like, for example, diabetic neuropathy or orthostatic hypotension, which can be neurogenic in amyloidosis.
So that's what I was wondering. And, we've had a conversation before about how do you address REM sleep without atonia without the clinical manifestation of dream enactment? And so it seems to me like this may be something that we should consider doing on our patients who have REM sleep without atonia, but have not developed dream enactment, or maybe they don't report dream enactment because they don't have a bed partner.
Indeed, that is a tricky question because REM sleep without atonia, without presence of RBD, first you should actually exclude that the patient doesn't have an RBD, which is not known, maybe because the patient sleeps alone. Indeed, in this condition, what I would suggest would be to monitor the patient, especially when you don't have a defined diagnosis. And you should not do with a patient and try to escalate the level of diagnosis. Don't say to a patient with isolated REM sleep hypertonia, you have RBD.
That's what I'm wondering, right? Because I feel like that is... we always want to make it make sense clinically, right? We're treating the person and not the test. And so we've had these conversations about what do you do with REM sleep without atonia? Is the answer just to follow and query them, ask them questions on symptomatic RBD? Or do we do orthostatics to see if maybe they are at higher risk of developing RBD? Or is this meant for people who have clinical RBD to determine who will progress and phenoconvert?
I would suggest to keep it as a standard for people with diagnosed RBD.
Okay.
I think that it is not either incorrect to have evaluation of orthostatic hypotension in a person where you just found REM sleep without atonia. I mean, as an autonomic specialist, I consider the evaluation of orthostatic hypotension as a part of my normal neurological examination. So they wouldn't be something I wouldn't do because you may actually also have the patients where maybe that could be not really well presented symptoms, where the patient could feel dizzy when he or she stands, but actually do not recognize the condition.
Oh, that's fair. So I guess that's true. If that's part of your evaluation on every patient, then for you, it's not a decision you have to make. It's part of their initial evaluation.
Yes, and I think is more in these cases being not an invasive evaluation, but part of an evaluation that can be in the bedside, neurological evaluation. I think it's more important on how you approach the patient than on what part of the neurologic examination you underline more or less.
Yeah, that's fair. That's fair. We learned about skin biopsies for RBD, but from what I understand, this isn't something that's available everywhere. And so I feel like what you're describing is more accessible. Do you do a lot of skin biopsies for RBD?
I mean, skin biopsies have helped us understand a very important pathological thing, that RBD is indeed an alpha-synucleinopathy. However, I would be a little bit more unsure to evaluate what the skin biopsy can do for the patient, because nowadays we actually know already that patients with RBD, with isolated RBD, are at higher risk of phenoconversion. And skin biopsies do not really help us a lot to identify who will be the patients at higher risk. Maybe also because even in negative patients, they could become positive over the years. And also because actually the vast majority of patients is positive. So it really doesn't help you to distinguish.
But is that true? I didn't know that. So the vast majority are positive.
Yes,
Oh,
in
I didn't know
isolated
that.
RBD, the vast majority is positive. But I mean, it has had and it has an important scientific meaning because it helped us to understand the true nature of RBD, also on a pathological level that usually it's a little bit trickier to evaluate pathology in brain disorders.
Okay. 2025 marks the 50th anniversary of the AASM. Here's Dr. Schenk telling us about his work on RBD.
And as it turns out, my first day of practicing sleep medicine was September 11th, 1982. And the second patient that I evaluated was our index patient with REM sleep behavior disorder. So my entire career in sleep medicine has been wrapped up with RBD. But I have to pay great tribute to Mark Mahald and our original and great sleep technologist, who also is a registered EEG technologist, Andrea Patterson, because I spent the night of September 16th, 1982, 5 days after I evaluated our index patient who complained of aggressive dream enacting behaviors. And 5 nights later, I stayed all night in the lab, very curious about what he would have, because he was never a sleepwalker. He had no prior history of parasomnia up until a few years before. And when I saw him in the lab, every REM cycle, he was jerking and twitching his limbs, moving around, unprecedented. But what I really recall the most was the next morning, I saw Mark Mahald, my esteemed late colleague, an EEG specialist besides being a clinical neurologist. He and Andrea Patterson were challenging each other to say, this is not REM sleep. This is seizures. No, it's not seizures. And they kept coming up with alternative diagnosis. And at the end, they said it has to be REM sleep. It was cyclical. It was associated with rapid eye movements, but the atonia of REM sleep had been lost. So I have to pay great tribute to Mark Mahald and Andrea Patterson because they definitively said this is a REM sleep disorder. Now, interestingly, Mark was a neurologist where they have a lot of movement disorders. So he initially called it REM movement disorder. And I said, look, Mark, I'm a psychiatrist. We deal with a lot of behavior disorders. This man is punching his wife. He's leaping out of bed. This is not a movement disorder. This is a behavior disorder. It's really a very active field of research, but it began at our hospital with Mark Mahald really solidifying that this is a REM sleep phenomenon. Bill Dement immediately recognizing the importance, organizing the 2 symposia at the meeting in July 1985, and now the whole field is involved. I mean, there's something for everybody, I think, with RBD.
Now back to our conversation. So help me understand this, and I say this as a pulmonologist. If someone has autonomic dysfunction via orthostasis, is that a sign? Should we send them to neurology?
I think that if a patient has neurogenic orthostatic hypotension, you should first exclude if the patient has diabetes or, more frequent conditions related to neurogenic orthostatic hypotension. And the first one is diabetic neuropathy. If the patient actually has orthostatic hypotension, if neurogenic, and you have excluded all other causes, it should actually be followed up because there is also the condition which is similar but also different from RBD, that is pure autonomic failure. That is a rare condition where you have a primary and isolated impairment of the autonomic nervous system that can be in relation with RBD. This patient can have or not RBD, and these patients also have a higher risk of phenoconverting to other alpha-synucleinopathies.
Just so I understand this, is the presence of neurogenic orthostatic hypotension, does that identify people at higher risk of phenoconversion, or does it mean that phenoconversion has already happened?
Neurogenic orthostatic hypotension marks the presence of an impairment of the autonomic nervous system. That if it is isolated, and when it's isolated in this patient, usually you find first the symptoms. The patients are highly symptomatic in pure autonomic failure, and then the patient will come to you because of these problems. You cannot say you are already converted.
Okay.
I would prefer to say that there are some areas in your brain that actually have aged faster than they should be, because that is also a better way also to communicate to the patient.
Oh, I like that. So you're just sort of presenting it as aging.
Indeed, that's a delicate question. I actually prefer to avoid deterministic language. I mean, I
Mm-hmm.
don't say you will get Parkinson's
Yeah.
or you will get neurodegenerative disorders. I would rather say that we have found some early signs that there can be some cells in your brain that have been aging and can be aging a little bit faster. And I always do this try of metaphor that there are patients who can have more problems to their joints in other parts of the body because we do not always age at the same speed in every part of the body. But it's to make them understand that it's a finding to monitor, but it's not actually a finding to be desperate of, because indeed we do not have disease modifying therapy up to now.
Well, that's what I was wondering. That are there medications if somebody is, does have neurogenic autonomic dysfunction? Are there medications to mitigate this?
Indeed, when orthostatic hypotension is symptomatic, the patient actually has a high difficulty in standing and in maintaining the standing position. It can also there can also be other type of associated hypotension, like postprandial hypotension. So the patient could feel dizzy after having eaten. And there are medication. There are symptomatic medication like midodrine, fludrocortisone, and more recently droxidopa. But it is also important to acknowledge the patient that there are also other non-pharmacological strategies that can be used.
Like compression socks?
Indeed, compression garments can be used. The first one that is always overseen, especially by elderly people, is increasing water intake. I mean, 1.5, 2 liters a day of water should be, especially for this patient, the bare minimum.
Okay. Yeah, isn't it funny? Because a lot of them have comorbid, like you said, diabetes, heart failure. So then we may be getting into an area where the recommendations are a little bit less clear. And so I like and I appreciate the way that you phrase, that our bodies age differently. We all age differently. And some of us have, advanced aging in our joints. And now we've identified something in the brain. I do think it's a really delicate conversation. We want to be truthful and we want to, without being fatalistic, right? Without saying, oh my gosh, you're going to develop this. It's more of a nuanced conversation. So I think having these signs, something objective that we can say, okay, this is, we think that this means that, that there are things that we have to watch for and to help our patients, right? Like take swing your legs out of the bed and, take a few seconds before you decide to stand, just sort of simple things like that, I think are helpful for our patients.
Indeed. I really think that we should concentrate on positive messages to the patients, and also in encouraging the patients once to be followed up. We say to the patient that if some problems may arise, we will be able to evaluate them and try to treat them, but also to advocate and to encourage for continuing to be active, because indeed, up to now, for neurodegeneration, for alpha-synucleinopathies, especially for Parkinson disease, what we actually have apart from symptomatic treatment is actually also, for example, physical therapy.
I was wondering about that. Yeah.
And yes, I mean, there is not a specific protocol for a person with RBD and maybe also probably comorbid neurogenic orthostatic hypotension to follow. What I would say them, I would just suggest not to just sitting on the couch all the day, but having an active life and practicing sports and just even something simple of walking 30 minutes every day could be a good suggestion to make to these patients.
Yeah, I was wondering about physical therapy because I wonder how many people interpret this as balance, that I have difficulty with my balance.
In this way, I think in patients with neurogenic orthostatic hypotension, it's important to make them understand what are the symptoms and how can they prevent the symptoms with therapies and countermeasures, but also how can they prevent syncopes, so transient loss of consciousness that can be also more problematic. We usually have in our clinic a list of, we can say, suggestions of lifestyle suggestions to follow that we actually give and explain the patients to follow.
So how do your patients respond to these conversations?
I mean, usually patients nowadays respond in a positive way, even if some patients may be some like surprise saying, you are just suggesting me to live an earthy life. I have to say that in a world where we are actually filled by information from everywhere, there are also patients where the discussion may be a little bit trickier because they actually come to you and say, I know they diagnosed me RBD, or you said they have RBD, but I know I will have Parkinson. And they ask you, do I have Parkinson? Or worst, when I will have Parkinson?
Yeah, and that's a hard conversation, but I think it's an important, that's an important conversation.
I think that in these cases, you should be truthful and you should be limpid in your way of saying. I always say to my patient that it's not actually relevant to know in their cases what is the yearly conversion rate or so on. What is important is to be active, to maintain an healthy life, and to be followed up. Also because in the worst eventuality, if a patient would develop Parkinson's disease, it doesn't mean the life is ended. We do not have disease-modifying therapies, but we have actually relevant and impactive symptomatic therapies. So even if the patient would develop some motor symptoms, this wouldn't mean it's the end.
So can I ask you a practical question? Where I am, tilt tables, that belongs to cardiology. So is this something that you partner with your cardiology colleagues to do? Is there a different protocol? Is this for you? Is this in the neurology department?
In the field of autonomic neurology, the tilt table has always been an instrument as a neurophysiological evaluation within and inside the autonomic clinic. It is, regarding the tilt table per se, something not so different from what is used in the cardiologist. The main difference is probably that cardiologists also do pharmacological stimulation with vasodilators. So that would be the main difference, and that in the autonomic unit, the tilt test and the other reflexes tests are actually coupled with beat-to-beat blood pressure monitoring that allows you actually to see the real response in real time.
Oh, that's cool. So do you have a protocol that you can share with us that we can put in the show notes?
I have, yes, we can share the protocol that we use. And in our unit, we also, some years ago, published and suggested a protocol for patients with Parkinsonian syndromes.
So any final thoughts for us?
I think that in these cases, really, RBD gives us a unique window in the earlier stages of neurodegeneration and experts really multidimensional, because it's a window for research, is a window for diagnosis, is a window also to teach us how to deal with the trickiest situation. So I think that it's an important time to be for sleep, autonomic experts, movement disorder experts, to collaborate across these disciplines, because I believe that answers will only come within the collaboration.
I love that. Well, thank you for joining us today and introducing a relatively simple test we can perform in clinic, which may help us to have better, more informative conversations with our patients with RBD. If you'd like to revisit conversations on this topic with Dr. Avedon and Dr. Howell, we will provide a link in the show notes. Thanks so much for joining us. Thanks for listening to Talking Sleep, brought to you by the American Academy of Sleep Medicine. For more podcast episodes, please visit our website at aasm.org. You can also subscribe through your favorite podcast service. And if you enjoyed this episode, please take a moment to leave a rating or review. For more feedback or suggestions, email us at podcast@aasm.org. I hope you'll join us again for more Talking Sleep. Until next time, this is Seema Khosla, encouraging you to sleep well so you can live well.